السلام عليكم. شلونكم طلابنا طالباتنا الأعزاء المرحلة الخامسة. We will continue our part 2 in seizure and epilepsy lecture. Today we will talk about generalized seizure. We have the first one is the absence seizure. There are two types, typical and atypical. We will talk about the typical simple absence seizure. We call the petit mal or petit mal, petit mal or petit mal. They are characterized by sudden cessation of motor activity or oral speech with a blank facial expression. There is masked face expression and flickering of the eyelids. And it is uncommon before 5 years of age, more prevalent in girls, never associated with aura, and it rarely persists longer than 30 seconds, so it is short, and not associated with a post-ictal state, may experience countless seizures, maybe hundreds per day, and the patient do not lose their body tone, and sometimes their head will fall forward slightly. Immediately, they resume activity after the seizure. Automatic behavior frequently is found as lip smacking, swallowing, or chewing. Hyperventilation for 3 to 4 minutes will routinely produce an absence seizure. So it is stimulating for the occurrence of this type of seizure. And the EEG here is typical, 3 spikes per second with a generalized wave discharge. This is the EEG finding, here 1, 2, 3 spikes per second. Complex absence seizure, we call it the atypical. Here there is motor component consists of myoclonic movement of the face, finger extremities, and suddenly sometimes they got loss of body tone. The seizure here will have atypical EEG finding as a spike and wave discharge at 2 to 2.5 seconds. This is a video show the absence seizure EEG finding, and here this is a video for absence seizure, and this is atypical absence seizure video. Now we will talk about the generalized tonic-clonic seizure. These seizures are common and may follow a partial seizure or occur separately. So the generalized tonic-clonic seizure, we call it the grand mal epilepsy, usually start as a partial seizure with a secondary generalization, or from the beginning it is generalized. There is piercing cry, high pitch, shrill cry, and the eyes roll backward. The entire body muscle undergoes tonic-clonic contraction, becomes cyanotic, and there is apnea. In the clonic phase, first of all, there is tonic phase, followed by the clonic. Tonic, there is a spasm, contraction of all the muscle. In clonic phase, there is rhythmic tonic contraction, alternating with the relaxation of all muscles. So there is tonic contraction in the beginning, followed by alternating movement of contraction relaxation. Persisting for a few minutes, children may bite their tongue, but rarely they vomit, and loss of sphincter control, particularly the bladder. Tight closing and jewelry around the neck should be loosened, and the patient should be placed on one side, and the neck and the jaw should be gently hyperextended to enhance breathing. Post-ictally, the patient are initially semi-comatose, and typically they remain in deep sleep for 30 minutes to 2 hours. In post-ictal state, here the face is often associated with vomiting and intense bifrontal headache. And this is the generalized tonic-clonic seizure. What about the myoclonic epilepsy of childhood? This disorder is characterized by repetitive seizure, consists of brief symmetric muscle contraction with a loss of body tone and falling or slumping forward. So here it is myoclonic. What do you mean by myoclonic? It is a jerky movement, very brief, but it is symmetrical contraction. Jerky, brief, symmetrical contraction. There is loss of body tone, they fall forward, and they cause injury to the face and mouth. What about the benign myoclonic infancy? Myoclonus of infancy, it is a benign, as we said, and it has a spontaneous remission. To occur during infancy, and there is a cluster of myoclonic movement. Usually it is combined to the neck, to the face, to extremities. Sometimes it's confused with infantile spasm. EEG here is normal. In patient with benign myoclonus of infancy, the EEG is normal. The prognosis is good because self-remission occurs within 2 years of age. No need for any anticonvulsant therapy. And this is the video for myoclonus. And this is another video for benign myoclonus of infancy. So typical myoclonic epilepsy of early childhood, not of infancy, they have unremarkable pregnancy or labor or delivery. Everything is normal and there is normal developmental milestone. The age usually about 2 years, maybe started from 6 months to 4 years, but the average, the mean age is 2 years. There is the frequency of the myoclonic epilepsy, it varies maybe once per days or per weeks. And a few patients, they have preceded by febrile convulsion or afebrile convulsion sometimes preceded this myoclonic epilepsy. EEG here is abnormal and one third of them they have family history of epilepsy. Mental retardation developed but in minority of patients. More than 50% they have seizure-free several years later. They outgrown the epilepsy, they live normal life. Learning, language problems and emotional behavioral problems may occur, but also in some of them. What about infantile spasm? Usually begin, this is very important subject. I want all of you to have it clearly in your mind. It usually begin between the age of 4 months and 8 months and are characterized by there is a brief, very brief symmetrical contraction of the neck, trunk and extremity. How many types of infantile spasm we have? First, flexor, second, extensor, and the third is mixed type. Flexor, it means there are cluster of contraction or volleys of contraction. They are in the flexion position. There is sudden flexion of the neck and the arm and legs onto the trunk. Flexion of these, the head and neck and arm, flexion to the trunk. Or in the extensor spasm, here there is extension of the neck and extremities. And this type is the least common one. But the most common one is the mixed infantile spasm, which consists of flexion volleys and extension volleys, flexion followed by extension. And as we said, this is the most common type. Sometimes in infantile spasm, a cry precede or follow the spasm. And this will make us to misdiagnose a case of infantile spasm as a case of colic because of this cry. And because of that flexion type, the patient will pull his legs to the abdomen and to the trunk as if he got colic. So sometimes we have missing diagnosis. The spasm occurs during sleep or arousal, and it have to develop mostly while the patient is drowsy or immediately on awakening. The EEG here, we call it is characteristic, and we call it hypsarrhythmia, like in this. This is the hypsarrhythmia. It is a bizarre shape and involve all leads, so it is generalized type. The etiology of infantile spasm, maybe there are two groups, maybe cryptogenic or we call it the idiopathic. It is account for 10 to 20%. It has a good prognosis. Or symptomatic infantile spasm, and these are related directly to maybe it is perinatal factors like ischemic hypoxic encephalopathy, congenital infection, inborn error of metabolism, neurocutaneous syndrome like tuberous sclerosis, or maybe structural abnormality like Lysencephaly and prematurity. This is number one during prenatal and perinatal, or it is postnatal in condition like if there is CNS infection after delivery, if there is head trauma, and also hypoxic ischemic encephalopathy. The prognosis, as we said, it is good in idiopathic type, but it is very bad in symptomatic type because 80 to 90% they have mental retardation. The pathogenesis, one hypothesis implicates that the corticotropin releasing hormone overproduction causes neuronal hyperactivity and hyperexcitability and seizure. So this number of as we said, the corticotropin releasing hormone receptor reaches its maximum. The receptor of that protein or that hormone, it is reaching maximum in infant brain, but with time followed by spontaneous reduction. That's why some of them, they go to spontaneous improvement even without therapy. So the treatment here by giving exogenous ACTH and glucocorticoid. This will suppress the corticotropic releasing hormone synthesis, and this may account for their effectiveness in treating infantile spasm. This video will show the infantile spasm. So uses of EEG to diagnose epilepsy. For what? The benefit is for demonstration of the paroxysmal discharge on EEG. Like as we said, it is hypsarrhythmia or 2 spikes or 3 spikes per second and else. And this during the clinical seizure is diagnostic. And a normal, we have to remember that normal ECG does not exclude the diagnosis of epilepsy, because about 40% of patients, they have normal EEG in spite of having epilepsy. Activation procedure, if it is negative, as we said, in 40% they are epileptic, but it is negative on EEG, we have to do activation of the procedure by doing hyperventilation, as we saw in patient with absence seizure, or eye closure, photic stimulation, and sleep deprivation. These increase the positive yield of EEG finding. The optimal medical management of epilepsy. What is our goal? First, here we have to ensure that the patient having a seizure disorder, it is not something like mimic epilepsy. Second, anti-epileptic should not be used. Never use in patient with febrile convulsion if the patient have first attack, if they have negative family history and normal result on physical examination and EEG, and if the patient family is cooperative and compliant, because 70% of these will not experience another convulsion, so no need to give anticonvulsant to febrile convulsion patient. Recurrent seizure, particularly if it occurs in close proximity to the first one, here we may begin anticonvulsant, but if it is recurrent and in the first 24 hours. The second step here of choosing of treatment, here choosing of anticonvulsant. And usually it depends on the classification of seizure, whether it is absence, whether it is, as we said, it is generalized, partial, myoclonus, and it depends and determined by the history and even the EEG finding. So the goal for every patient should be the use of single medication, one drug only, and with the fewest possible side effect to reach control. And we may increase the dose slowly, gradually, till reaching control, or until the undesirable side effect appear. If complete seizure control is accomplished, if the patient is improved, and by giving the anticonvulsant, a proper one and the proper dose, here a minimum of 2 years free, seizure-free years is adequate and safe period of treatment for patient with a no risk factor. So for how long we are going to keep the patient on anticonvulsant? It is 2 years after the last attack. Recurrence occur during this period? Yes, recurrence might occur in 20 to 25%, especially in the first 6 months after discontinuation of the anticonvulsant. Okay, when we decide to stop medication, to discontinue the drug, we have to start weaning. With this weaning, it takes about over 3 to 6 months, because sudden or abrupt withdrawal may cause status epilepticus. So the common anti-epileptic drugs, carbamazepine, or we call it Tegretol for generalized tonic-clonic or partial seizure, exotexazomide, Zarontin for absence seizure, phenobarbital for generalized tonic-clonic seizure, phenytoin dilantin for generalized seizure and partial seizure and status epilepticus, valproic acid, generalized tonic-clonic absence and myoclonic. ACTH preferred drug for infantile spasm, prednisolone also is effective treatment. What are the common side effects of Tegretol? Usually it is used for a focal type of epilepsy. There is nausea, vomiting, dizziness, drowsiness, dry mouth, swollen tongue, loss of balance or coordination, and unsteadiness. Thank you.